Welcome back, dear friends. Glad to see you all after that delicious lunch. Your presence shows that you are eager to feed not just the body, but also the mind, intellectually hungry. So, let's dive into our next session together. For the next session, I am pleased to introduce the next speaker, Dr. Ashish Kumar. Dr. Ashish Kumar is the Assistant Professor in the School of Computer Science and Engineering at Zyme University, Bhubaneswar since December 2022. Prior to that, he has worked as an Assistant Professor at Geetham University, Hyderabad and Birla Institute of Technology, Mesra, Ranchi. He has completed his MTech and PhD in Computer Science and Engineering from IIT Dhanbad. His research interests include blockchain, cryptography, cybersecurity, network security, and wireless sensor networks. Dr. Ashish, the stage is now yours.
Thank you, sister. So, good afternoon, everyone. So, welcome back after a good lunch. So, this session is about technology, right? So, the topic of this session is technology as a catalyst for mission sustainability. Means why we should use technology and how technology will help us to improve ourselves in our day-to-day life. So, we all use technology in our day-to-day life, right? And believe me, in this entire session, I am not going to discuss very complex technical details. I am not going to give, but I will tell you that how a small, simple technology can improve our efficiency, give better output, and make large change in our day-to-day work, and also in the long-term vision of this chai. So that we will discuss. Before discussing this, I would like to give a short group task, and after that you will keep the answer or keep the chart paper that will be in the chart paper. So you will keep the chart paper with you. At the end, means around 5 p.m. I will again give the same task, and then you will have to again do the task quickly, and then you will have to present. So that is very short thing. That will not be too much lengthy, right? Okay. So beginning, I am going to start with the task, and that is very simple task. What you have to do in the chart paper, group wise, you will have to, I am showing it to you. It is not coming. And for online participant, I want to mention that I am using Chai Session-2, slide number 19. Yes, it is. No, actually, yeah, that was duplicate करना पड़ेगा. Okay. Thank you very much. So the thing is, yes, nothing to do, just see as a Chai Network hospital or healthcare center, what challenges you have faced so far. Challenges can be there will be shortage of doctors in your organization or in your centers, or there is a shortage of drug supply, or there is low patient trust, or you are losing the patients, means you are not getting that much patient, there is a decline in patients, or there is financial sustainability issue, or there is some maternal mortality in your area where your center is there, or some poor record keeping thing is there, or there is some audit challenges in your center or in your hospital. So you can pick one or more than one challenges, and after picking the challenge, you need to write that what strategy you have followed so far, right, so that the challenge can be removed. And for that, have you done any collaboration or have you used any technology? If used, then what technology you have used, or if you have done collaboration in real, then what collaboration you had done. Understood? Just you have to write, our challenge was this, our strategy was this, our collaboration was with those organization or those people, and we have used those technology. Only 4 lines you have to mention. Just identify what challenge you had faced, and then mention that strategy that you followed, and collaboration if you have done, and then technology what you have used, right? So I am giving you chart paper as per the group wise. You please mention, right, technology, challenge, and collaboration, right, with the strategy. Yes. You can mention other challenges also if you had faced in past. Sorry. Oh, you want? And I will request everyone that please give the answers honestly, right? Do not give the answer hypothetically that I have used so many strategies or so many technologies we have used. So what practical thing that you have done in the past that you mention?
सर आप मुझे बताएंगे क्या क्या बोलना है क्या क्या करना है सारी विधि 2 minutes it is over.
Yes.
You should be stick to the
You will have 2 more minutes. That's all. One more minute you have. Done? Thank you. Okay. Time up. Time up. Time up. All of you, time up. All of you. Please. Hello. Ma'am, that group, time up, time up. Right, sister, time up. So it's over now. Now, now, that's fine. Hello. Please don't do discussion. Okay. All right. So I'm going to start my session. Now the thing is, you have done the task. You will keep the chart paper with you. Now next time again I will give you the same task. After my presentation, what you will do, you will give the answer in the back side. That's all. Right? So okay. So, madam, sister, please, this side.
Now you can turn your gesture, posture, everything.
So, roadmap of our presentation is, we will discuss why technology is required in our day-to-day life and also in our hospital networks. And then I will also discuss the 4 technical pillars that can be used in our CHAI hospitals, right? Like telemedicine, electronic health record, data for decision making, and digital fundraising. Thereafter, I will discuss 4 case studies, brief case studies will be there, from Aravind Eye Care, Narayana Health, Smile Train, and MSF. MSF is Medicine Sans Frontiers, right? So these case studies are from different organizations in India or world, right? Thereafter, I will give you one MCQ type, means you need to give the answer, and then there is no right or wrong, just give your opinion, that's all. So that is the reflection part, and thereafter we will conclude this session, right? And after this, I will have a brief session on collaboration, that is the another part, but going to this technological part. So the topic is technology as a catalyst, right? Means technology will help us to improve our efficiency, to improve our day-to-day work, right? And will also facilitate us to do the work easier and better, right? So why we use technology? Without technology also we can survive, but why technology is required? Technology actually makes our life simpler, save our time, and help us to do the things in a better way. From the morning when we wake up, right, we start digital technology, like we wake up with the alarm in the mobile phone, isn't it? And then we start checking our WhatsApp messages, and thereafter throughout the day we do online shopping, we surf internet, watch videos, do ticket booking, right? Or many things, isn't it? Do communication, do video calling, many things we do in our day-to-day life for ourselves, not for the organization, right? So why we are using, means can we imagine now that without technology we will survive? Is it possible? Without, means zero technology uses, can we survive? No. It means that now the technology is not the luxury thing, it is part of our survival. Without that we cannot survive, right? So that is why technology is needed, right? It will help us to save our time. Now we used to do calculation manually, now calculator is doing it very faster and efficient way, and it is also reducing the error, isn't it? Also we can use technology to connect the world. Now the world is becoming day by day smaller, isn't it? So we are now having a very small world, we can connect with anyone anytime, isn't it? Then it helps us to make our life simple, make the things simple, make the complex task simple. And definitely it is less error prone. With the use of technology, the chances of error is getting reduced, and it is enhancing the safety and reliability. You will get correct answer, you will have better world with the technology. Now this technology can be used in our hospitals. If yes, then for what purpose? We use it, but occasionally, not in a formal manner. Occasionally we use it, right? Especially those who are working in rural areas, isn't it? They are using WhatsApp for communicating with the patient, right? So, or sometimes patient or the people who are residing in a village, they used to send the medical reports or give the prescription, photo of prescription on the mobile phone, or may send you through WhatsApp, isn't it? So for that purpose we are using it. Record keeping also, sometimes we use MS Excel, MS Word, right? Those things for record keeping. If there will be any audit, we will mention all the things and will send it to them. It is a small scale, but we are using. Payment and billing. Now in hospital, if you are going for the consultation, you can do online payment, right? Pay the bills, pay the pharmacy bills, pay the medical checkup bills. So that can be done through the use of technology. Consultation, especially during the COVID period, we used video consultation, right? Then also we can use technology for, nowadays we are using app for medicine reminders, because the dosage of medicine are so complex. Earlier we used to have a medicine that one medicine is prescribed morning, evening, and for 3 days. Now since the problem is growing, the pattern of dosage is also getting changed. Now alternate day this medicine you will take of this power, and remaining day you will take this medicine of this power. First 3 days you will take 3 doses, morning, afternoon, evening, and after 3 days you will take only 2 doses. That may be the case. Now it is not possible to memorize all the things, so nowadays reminder apps are there. We can use it, right? Many people are using it also. That's a free of cost thing. We can use it in our day-to-day life. So for many things we can use technology, but that is still informal. We are not using it formally, or even though we are using it formally, as per my knowledge, which I got from reading the mission, vision, and all the challenges that CHAI is facing, right? From that I conclude that for large scale integration of technology is not there. Maybe 1 or 2 hospitals or maybe 1 or 2 health centers are using it, but for the large scale we are still not using it. Now why we should use and what technology we should use, that we will discuss. So I will discuss 4 pillars. There may be many, 4 pillars, right? First is telemedicine. Have you heard about this, telemedicine? Yes. So it is very popular now, especially when we had COVID. From that time we are using telemedicine. Now why telemedicine? See, telemedicine is doing lot of things. Lot of things means it is removing the imbalance. Telemedicine is actually removing the imbalance. How? Suppose in CHAI network you have very good hospitals in the cities, but not in a rural areas. Now through telemedicine, the area which is not privileged or area which is very poor, that area can have the medical facility through the use of telemedicine, right? That can be virtual facility. Second benefit is that in rural areas you do not have any tension to build the infrastructure, because you have infrastructure in the city. you do not require to build the infrastructure in rural areas. With the existing infrastructure, you can provide the service in rural areas. That is why telemedicine is good for the organization. So basically it connects patient of remote areas to CT specialist, and there can be different mode, audio, video, or exchange of messages. Through that we can do the consultation, we can do the communication. A remote patient can communicate with the specialist. Second thing is, what benefit the patient will get? The patient time will get reduced, and also the patient money will get reduced. The patient expenses will get reduced, isn't it? Right? So that is a big benefit. In rural areas, saving time, if a person will save time, you know better that if someone will save time, he can do some work for the earning, instead of going to city and get the doctor's consultation. If he will save money, that will be a big thing, right? So it will also empower our sisters and nurses. How? Because the point of contact of the patient will be now sisters and nurses. Now they will help them to connect with the specialists. They will decide which specialist will be good, which specialist will be fit for that, right? So the nurses and sisters will also get empowered by them. It will also build trust in the local health centers, because with the local health centers, they are getting the facilities that are being provided in the cities, isn't it? So that is why telemedicine is having a lot of benefits, isn't it? Good. So I'm saying that it is becoming boring because after lunch having so much theory sessions, right? So no, I'm just telling you the reality, right? Second thing is EHR, electronic health record. This is the second pillar which I had chosen. Now why electronic health record is important? See, electronic health record, have you heard about this? Yes. So electronic health record actually removes our too much paperwork, right? And this not only removes our paperwork, but it also removes the complexity. What complexity? First, it helps the patient that the patient do not require to carry all the prescription, all the history and all the reports with him, right? Anyone can access those things from anywhere. This is the benefit of electronic health record. Second thing, duplication of test will be removed. If I will go to hospital A, they will say for the X-ray. Again, for the follow-up, I will go to hospital B, they will again ask for the X-ray. So those things will not require, because one X-ray, and if it will be in an electronic format, anyone can see, right? There may be different issues that I'm not going into that, but the benefit of electronic health record is this, right? Also the third thing, if a hospital is accepting some insurance, medical insurance, so all the compliances will be fulfilled automatically if you'll follow or if you adopt electronic health record, isn't it? Because every information, if a hospital or health center is going for the audit, if you have electronic health record, there is no any problem. One more thing, if your organization is having multiple centers, then also electronic health record is very much useful. Because if you'll have electronic health record from one place, you can manage many things, right? Otherwise, it will be purely decentralized and lot of paperwork, lot of complexity, right? and also it will reduce the errors. So this is the second pillar. Third pillar is data for decision making. Nowadays, sometimes in Delhi, during this time, October, November, there will be dengue outbreak. Every year they used to have. There is a pattern, right? Before Diwali or after Diwali, they will have dengue outbreak. Now, if a hospital will have those information, they will manage the manpower beforehand. So it is not about only the managing manpower. So decision can be taken without any prediction. Now, if you have data, for an example, if you have adopted electronic health record, now you have data on your computer. Now you can process those data and create multiple information, right? With the data, means that information will be evidence-based information. That will not be a simple guesswork. So with the evidence-based information, now you can do what? You can analyze the thing in a better way, and if you have any thing to decide, you can do it in a better way, right? So you can anticipate peak times, you can manage staffs when there is a peak time, when there is not. You can also maintain the inventory of the pharmacy, right? And you can check if there is shortage or not. Beforehand you can fill it. So these benefits are there. And with the decision making, we can do lot of things. So nowadays AI is there, artificial intelligence. If you will adopt artificial intelligence with sufficient data, nowadays many problems can be solved, right? So I am not going into the detail of how it will solve the problem, but yes. So that thing can be done. Fourth is digital fundraising. You have all the thing but lack of fund, right? So that will not help you to do what you want to do, isn't it? So fund is important. Nowadays, if you have decline in traditional funding, still you can adopt different mechanism to get the fund. What they can be? Digital funding. Digital fundraising means you can use websites. You can increase your visibility. With the increase of visibility, with the presence in social media, now you can advertise yourself. You are doing lot of things, right? You are doing lot of things in the different areas, right? You are working on different diseases, leprosy and HIV, TB, many critical diseases. If you will showcase what are you doing on social media, right, that can help you to get the funds from different agencies, or from under the fund from CSR, right, or from you can have collaboration from government agencies. These things we will discuss in detail in the case studies, right? So this is our fourth pillar. Clear? So first was telemedicine, second was electronic health record, third was data for decision making, and fourth was digital fundraising. So 4 pillars I have discussed. There can be many, but I think these 4 things, if you'll adopt from the in a very basic manner, still it will help you a lot, right? Now going to the case study. So I'm going to have first case study. So this case study was discussed in the morning by our Father VC. Father VC also discussed another case, another organization. So that case study I will discuss here. So I got afraid that Father will discuss everything than what I will discuss. Because he took the name of LV Prasad, he took the name of Aravind Eye Care. So everything, every name he was taking. So that is why I got worried. Now the first case study is Aravind Eye Hospital, right? So Aravind Eye Hospital is very famous. It was founded in 1976 by Dr. Govindappa Venkat Swamy, right? So he was perhaps a government employee, and post his retirement he started this. So he started with 11-bed hospital, and now it is world largest eye care provider. So he was very good eye doctor, and the vision of this hospital was to eliminate needless blindness. So it is purely focusing on eye care, right? So what was the initial challenge? Initial challenge was that there were many villagers who were having cataracts, and that can be cured, but due to lack of facilities, they were not able to get the treatment. Nowadays also we have in rural areas it is difficult to get the surgery of cataract. In rural areas, not in the urban areas. So the problem was poor had limited access to the hospital, eye hospitals, and poor patient also avoided to go to city and get cured. And because of this partial blindness due to cataract, now they got trapped in a poverty because of lack of efficiency. So these were the challenges. So what he decided to set up a telemedicine camp in different villages. What actually Dr. Venkat Swamy, he used to go to villages in the weekend at the time of his before retirement, right? He used to go to villages, and from morning to evening he used to do cataract surgery. So from that he understood that there should be multiple village camps, and he set up multiple village camps. But again the thing was lack of fund, because he was not having good funding. So what he decided, he took basic things, basic equipments like slit lamp, fundus camera that used to check the eye, retina, right? So those things he used to carry, and he set up many temporary vision centers in the remote areas. And thereafter he hired few technicians or few nurses on daily basis, and then he asked to go and carry the pictures. And in the city hospital there were eye doctors, specialists were there. The technician or the nurses used to send the pictures of the retina or eye, and the specialist sitting in the city used to give the prescription based on the image. Now it has helped a lot to the village people, right? So this way they had started multiple vision centers, and nowadays they have done 5 million plus patient screened, means they have done this kind of checkup in the village area, 5 million plus. It is a very big number, because, and also this vision centers in the remote areas also help people to reduce their travel cost and waiting times, because health centers or the vision centers were inside their village. Also, patient received care within their community, and up to now they had done around 400,000 plus cataract surgery, and that was successful. And that is why they have a good name in the field of eye care. So their success factor, if you'll see, the success factor was low cost technology, task shifting. Now specialists are just checking the images and nurses are engaged in taking the images. Now both are on the work, so that is why workload sharing was done in a better way. And also there was a cross subsidization model used by Aravind Eye Care Hospital. So father told in the morning about the cross subsidization. So cross subsidization means that there can be multiple categories of patient. A patient with having good background, in financial background. A person may have very bad financial background. Now we need to distinguish between them. From the person who is having good background, you can charge more, and those who are very poor, you can give the free of cost treatment. So this model, cross subsidization model, they have adopted, and this way they become famous, right? And so if you, this is again the example of telemedicine, right? So if we will discuss about the lesion for chai, the telemedicine can be adopted at low cost, right? And tasks can be shared between the nurses or the technicians and the specialist, and even you can do the work in a small hospital with the facilities equivalent to the city with the use of telemedicine. And if you'll adopt cross subsidy model, then it will help you to serve the poor as well as those who are having money, right? Again, the second example, second case study is about Narayana Health. Now Narayana Health, in 2000 it was started by Dr. Devi Setti. Now this is in Bangalore, right? So what he did, he started this with a mission that affordable health care for the masses. Now affordable health care, so far they, I don't know about this, but so far they claim that they do the cardiac surgery at very minimum cost, around 60,000 rupees. They do cardiac surgery to common people, and that is very much cheaper than the entire world. Means with so much less money, you cannot do cardiac surgery with. So for the common people I am saying, not for the poor, right? They do, and what they did, so slowly with this low cost treatment, they have expanded themselves and created multiple network hospital. Now they are having 40 plus network hospital. Narayana Health is having 40 plus network hospital, and they have done this, they have achieved this within 15 years. Right? In a very short span of time, they have achieved this. Now they face that, since I told you that if you have multiple hospital under one network, what you can do, you can have electronic health record, so that at one place you can manage all the data, you can check all the data, and there will be no any discrepancies. Also patient will get benefited from this, and there will be no requirement of repetition of test and all. Now for that he used EHR, and EHR provided a unified patient database, and with one database they can manage the data of all the networked hospital, 40 plus hospital data at one place in your fingertip. Also it was now have started giving facility of medical insurance, and it was with the compliance of with the regulatory, according to the regulatory compliance, right? And it was also having analytical dashboard. So with data, since the data is at one place, now they use to modify the data, process the data, and get the information. So data analytics can be done if you have sufficient amount of data, right? So what impact it had provided is cost saving, because the patient now is not required to do the same thing again and again. So it is saving the cost of the patient, and also it is enhancing the efficiency, because how efficiency is achieved? Because now doctor is getting entire history of the patient within a minute, entire history. Otherwise it is very difficult for a patient to carry all the things since childhood. So it is very difficult. Third thing is transparency. Now since everything you are capturing in the database, so now the data is very transparent, and it is easier to compliance with the insurance companies, especially the government insurance like Ayushman Bharat or other state insurance policies. Scalability can be achieved. Now today you have 40 network hospital, in future you can have 80 network hospital, and you can use same database. So once implemented, you can use it for many years. Now this success factor can be replicated to CHAI. So even a small hospital can start with basic digital recording of the patient. Digital recording means you can keep the information of the patient in Excel sheet, right? You can reduce the compliance burden. You can improve the continuity of the care, because once a patient will go to your health center, then he will approach to your higher hospitals for better treatment or for follow-up, right? So for those things, there will be no any break in the care, right? So every information that the health center will provide, that will be available with the city hospitals. It will also help in resource management, right? Third case study is, I will not take time, but discuss this third case study. Smile Train. Smile Train, have you heard this name? Yes. So it is very famous, right? So what they do, the Smile Train, they do surgery. What kind of surgery? Right, right. So this organization started in 1999 in New York, and it is world largest cleft focused NGO. This is an NGO. So what they do fundraising, they show their success story in the digital world and get funds. They do collaboration with different hospitals and get the surgery of children done in those hospitals, right? And you cannot ignore them, because they have done so far very large number of surgeries with this with only fundraising, right? So their mission is provide free cleft lip and palate surgeries to children in need. So those who are having these types of problem, those children the surgery can be done for them, right? So in India, it is the organization belongs to New York, but in India, it is one of the largest program countries for this Smile Train. India is the largest program country. Means for India, they have done so far hundred of thousand, around 1 lakh of surgeries so far in India only. In India, if you'll see about India only, so we have 35,000 children born with clefts every year. Now the challenge is, people in remote areas or rural areas, they do not afford surgery, or second thing is they do not know whether this can be cured also. They have no idea, right? So that is why it is the biggest challenge. They are poor and they have no idea that this can be cured. And second thing is that traditional donor funding is insufficient for the large scale, means 35,000 every year, you cannot do with the traditional donation, right? So now what they did, they started digital fundraising, and digital fundraising, they started with very small amount of donations. So donations can be, their donation can be around $20 also. So micro donations they used to accept, because they know that if I want donation for long run and from large people, so we require to accept micro donations also. So micro donation is easy to give, right? Because it's a normal mentality. I was there in a mall and someone asked me in the mall that we are a NGO and doing some good thing for children, so can you give money? I said, how can I give money? I do not have money right now. So they asked that if you have 100 rupees, we can also accept. 100 rupees I can easily give, right? So micro donation they started. Then second thing is storytelling. If you'll go on YouTube and search the Smile Train, you will have lots of good videos. They will say that before this boy was this, and now this boy is, the surgery is done, and this boy is cured, and we had done this surgery at this place. So all the information they provide, right? So they do storytelling, and they post the stories on YouTube, Facebooks, and different places, online portals. They also did the partnership with different organizations, like government organization or different companies under CSR. They started accepting the funds. So initially no one will give fund, right? So donation, micro donation you can collect, and if there will be a good success story and there will be transparency, then you will be able to do partnership. So the impact is, so far they have done 1.5 million surgeries, and in India only they have done around 1 lakh surgeries. So their model is very sustainable and does not depend on any large big donors, right? Big industries, big organizations, they do not depend on them, right? And they have very, their visibility is global. So now it also helped the local doctors, because what they do collaboration with hospitals, and they used to say that I will give you 30 children for the surgery if you'll accept what rate you will charge, and this is purely for the, means there is no any profit is involved here. So how much you will charge? So they do such kind of partnership with different hospitals, and this way they also empower the local doctors and hospitals in India, because hospitals are getting patients and they are providing patients at very nominal rate, means nominal cost. Now the success factor, if you'll see, it is emotional storytelling, digital fundraising, global plus local model, and scalable operation. Emotional storytelling, you can see on YouTube's. Digital fundraising, so you can do digital campaign for funds, and you can have international donor and can implement the thing at the local level also. So digitally, this is very good thing, that digital campaign can attract people from outside India also. And the operation is scalable, because the number of patients are large, right? So what you can do in a similar way is that you can also have digital fundraising with the storytelling. You can also enhance the visibility through social medias, right? And you can also have the collaboration with different organizations, so they can fund you under CSR. And you can also run a campaign that sponsor a patient that which they had done. So sponsor a patient means if someone is rich, they can sponsor a patient, means they can sponsor the treatment of the patient, right? So first, do the treatment at nominal cost and ask for small donations. That will work, right? And most important thing is maintain transparency, because if you will not get fund if you will not maintain transparency. Transparency means that if everything will be fine, then you will get fund in the long run. Otherwise, you will see the decline in funding, right? So transparency is important. Nowadays, you can see there are donate cards. Have you heard about donate card? Milab Foundation and many portals are there. Have you heard about them? In YouTube, we used to see ads of them. Donate card, Milab Foundation. Donate card was built in IIIT Hyderabad. So the students of the IIIT created this app, and now anyone can take part in this app, join this app and ask for funding. Now the thing is that earlier it was good. Now you can see few fake people are also asking for the funds. So that is why you will see there is decline in the funding through this portal. Because if you will not maintain transparency, if I used to give funds, donations, not fund, donations I used to give. For an example, we have a good mentality. So on the day of birthday of my child, I can donate few things. On my birthday, on my grandfather's death anniversary, I can donate something. So these things can be done, but you need to maintain transparency. So transparency is required. If there will be lack of transparency, there will be decline in the donations. And the last case study is Medicine Sans Frontiers. Have you heard about them? Anyone heard about this organization? Yes, yes, Doctors Without Borders. The organization name is Doctors Without Borders. Now it is a French organization, right? So because this is a French organization, the name is Medicine Sans Frontier. For English speaking people, they have changed the name, and the Medicine Sans Frontier is translated into Doctors Without Boundary. Now they used to work in the places where no one used to go. So it started in 1971 as an international humanitarian NGO, and it is currently operating in more than 70 plus countries. So their vision is, their mission is provide impartial emergency health care to people in crisis. So they used to generally work in war zones where there are huge number of refugees, or they used to work in the areas where there is epidemic outbreak. So such places where no one used to go, they used to go and serve the people. Now there is a lot of challenge. It is not easy to go. Just going there is not an easy thing. Fulfilling the purpose is important. So the problem is there is a chaotic and resource poor environment, right? Because it is a war zone. So if you are going into a refugee camp, you will not find anything organized. So there is no proper hospital facility, there is no proper electricity facility or anything, connectivity, even internet connectivity you will not find. There will be huge number of patients and very limited number of medical staffs you will have in those areas. And also, since it is a war zone, refugee camps, you will not find any reliable records of the patients, right? Because everything is vanished. Now, it is also difficult to track epidemics. Who is going where, from where it started, you cannot track easily, right? And that is why it started searching for technology, and later they used technology to manage those situations, to manage patients, medicines, and outbreak data. So they use technology to manage, to sort out all the things. So what they did, they are using ComCare mobile app. Now ComCare mobile app is the open source mobile app you can also use. Anyone can use. This is a free of cost. Now this mobile app they are using, the benefit of this is they are offline first mobile app. Means that you can feed the data into that app, and then later when you will get internet connectivity, the data will be shared to the server. So without internet also you can feed the data in this app, and when the app will get network connectivity, it will upload the data to the server. So it is one of the good app for working in those areas, or working in areas where there is very poor network connectivity. Next is they have followed EMR. They have adopted EMR, right? And EMR, electronic medical record, for different patients like HIV, TB, or other critical diseases. They have also used telemedicine platform. Telemedicine platform means what they do, very few people will go into the war zone area. Now for contacting the specialist, they used to do some consultation with the doctors outside the country, so that they can do consultation. So they also consult different specialists. So they have hired few specialists, or have done some collaboration with different people. And they also provide real-time tracking of these communicable disease patients. Means who is going where. Their app used to take GPS data. So during COVID time, we had one app called Arogya Setu. So they used this app used to track that which patient is going where, what is the area in this in this proximity, how many patients are there. So all the information they used to more or less correct, not exactly. Every information was not correct, but it was giving us the average idea that what is going on in this locality, how many patients are there. So these things helped us to curb this corona, what I feel. Now, impact of MSF is continuity of care. So they provide care. Continuity of care means there is very less dropouts. Dropouts means that few patients are going to visit the medical centers. Now after few days they will not go, and they will go to somewhere else, or they will not go for the treatment again if they find it difficult to get the treatment. So if they will find it easy, comfortable, then they will have the continuity, right? Then they have very faster epidemic response and better resource management. They are having good collaboration with different people, and they maintain transparency in a better way. So success factor they are having is adapted to local reality, empowered local staff. They did partnership with different organizations, right? So ComCare is the open source app that is provided by one organization that is called Dimagi organization. So what they did, they have created this app only for those purposes. Now the app is free of cost. They had given to this MSF, so they had made this app open source for everyone, right? So from this we can learn that we can also use ComCare like apps or similar apps, right? We can also use telemedicine platforms, data dashboard we can have, so that it will give information that what is the status of what hospital, right? There will be unified platform. There can be a unified platform for all the networked hospital comes under CHAI, or all the health centers. So with this app, you can have all the information in your fingertip. Also, if you'll have transparency, you will maintain transparency, you will get fund, or you will be easily able to collaborate with different government schemes and different government organizations. So these 4 case studies I discussed so far, 4 pillars I have discussed, right? Now, since you are feeling sleepy, so I want to give you some task. Break. Yes, you can take break, and tea is not ready. So after so now here what you have to do, take out your mobile phone since you have internet connectivity. So scan this QR code and fill a form having 8 questions related to those case studies. Not able to hear, ma'am? I am saying that you please, all of you, not in group, individually, use your mobile phone since it is having internet connectivity. Scan this QR code. You will find 8 MCQs, 8 multi-choice questions. Now there is no right and wrong. It will just help us to know what is your perception, right? So 8 questions are there. You will give the answer there, and thereafter we will do some analysis. Then they will go for, it will hardly take, ma'am, 5 minutes.
Yes.
It is requested that the members from nature region may come in front of this stage for a photo session after filling the form.
Okay. So far I got only 88 responses, and I am told that the strength is 132. So I request all of you, those who have not filled, please fill it so that we can compile your response, and if required, we will give it to you, give it to your organizers, and also will keep with us for the record. So around 40 people have not submitted so far. Please submit it. Okay, QR. Please find the QR and scan it, submit it. All right. So far I got 90 responses, including the faculty members. So now I am going to, because I am running out of time, a lot of things to cover. So going to read your responses so that you will be able to understand that what is the variation. It is not about right or wrong, right? You may have your own opinion. So 4 options were given, any option you can choose. So now based on your responses, now I am going to analyze it. So first question was related to telemedicine, that if a telemedicine model like Aravind was offered to you, how willing would you be to try in your hospital or in your health center? So here 38% of participants have said that they are very willing to adopt the telemedicine thing, like Aravind did. And 48% is ready, but they require some guidance, they require some demo, all the things. 8.5% are not sure about their organization whether they should adopt or not, or means they are not very much sure about it. And 4.3% means 4 people have said that they are not willing to adopt the telemedicine thing, because they may be, their organizational structure may not support this telemedicine thing or whatever. So this is the result where majority are either willing to adopt it immediately, or they are ready to adopt if the proper guidance will be provided to them. So this figure is around more than 80%, around 90. Now the second question was, what do you think the biggest benefit of using telemedicine in small Catholic hospitals? So can we use telemedicine in our small health centers? So 48%, around 50% said that the telemedicine can save patient travel time and cost, correct. Few found that it will increase the trust in local hospitals, because telemedicine they will adopt, so everything the patient will be happy that they are getting facilities like the facility provided by, or they are getting consultation with the doctor that is sitting in the metro areas. Now 30% said that it helps hospital to reach more patients, because more and more patient will come, they will avoid going to other means check other options if you'll use telemedicine in your organization. 8.5% said that it will reduce workload for doctors. So doctors' workload will be reduced using the telemedicine. Now question was, what would be the biggest benefit of using digital patient record in your hospital? If you want to implement EHR, electronic health record, or digital record of patients, then what is the benefit? So 75% around people have said that it is easy to access patient history, that is correct. And 14% said that better planning of hospital resources using patient records. And 10% said that fewer repeated tests and error will be there. And around 2% said that it is easier to compliance with the government and insurance companies. How ready is your hospital to implement EHR, electronic health record? So 52% said that we are already using it in some form. So they are using electronic health record in one or another form, right? So they may use basic softwares or open source software for that. 22% said that we can start soon with the training, and another 22% said that they are interested but needs funds or support to implement electronic health record. Now 3% said that they are not ready at all. So around 3 to 5% people are there who are very negative. No, this is just a joke. Maybe their infrastructure or their structure is not allowing them. So that was just a joke. What kind of digital fundraising approach would work best for your hospitals or health centers? So here 40% said that CSR partnership with corporates will work for them, and around another 40% said that online donation platforms or micro donation can help, and 12% said that another 40% said that sharing patient stories on social media will work for getting funds, and 12% said that online donation platform can be built to get the funds, and 7% said that sponsor a patient campaign can be useful for their hospitals. Now, if Chai supported it, how willing would you be to run a small online fundraising campaign for your hospital? So, using online platform, would you like to run the campaign for fundraising? So 56% said that yes, they are very willing and they can try it very soon. 33% said that they are interested but need training and support, right? Now 7% said that they are unsure, may be difficult in their own setting, and 3% said that they are not willing. What area of hospital management would benefit most from better use of data? So if you are having, if you have implemented electronic health record, or if you have collected data in a proper manner, so what area of hospital management would be benefited? So 67% said that patient follow-up, chronic care and maternal health. 18% said that stock and medicine management can be easy to do. 8.5% said that reporting to government and CSR donors, so they require data, transparent data, so that will be helpful for them. And few said that bed occupancy and staff duty planning can be done in a better way if you have proper data. So with data they can do these things. Next question was, how confident are you that your hospital can start using data dashboards or simple reporting tools? 48% said that their hospitals are interested but need guidance. 40% said that they are very confident, we are already doing it. And few people are unsure, 5% are unsure, and another 5% are not confident about their hospitals. So these were the summary of the feedback that I collected from 94 participants. All right. So this data can be used by the organizers. Now, I'm going to conclude this. See, there is a myth that if you'll use technology, then it will cost you a lot. So if you'll integrate your hospital with the latest technologies, it will cost you a lot, and it is not suitable for small health centers. It is good for the corporate hospitals. So this is a myth. You can use, the reality is that you can use technology for even a small hospital, small health centers, right? And it is not necessary that your tools or technologies which you will integrate with your centers will cost you a lot, right? There are many free tools available. Now it is up to you. See, if you'll not pay money, there will be some limitation. Someone asked me, but there will be some limitation. But if you'll choose wisely what technology you want to use, somewhere you can find it free of cost initially, right? So there is a jugaad technique. Jugaad technique means, I'm saying that free of cost version you can use, free versions, right? So that I will discuss. Now, see, in 1976, Aravind started. In 2000, they adopted this. 2000, they adopted this telemedicine thing. That time, using telemedicine means there should be a good vision, right, for implementing these things. And that is why their success stories are said everywhere, because of this vision. So they integrated technology that time. So the technology was not complex. At that time, they used to do the things on simple computers. Now they have good softwares, efficient softwares, right? Because they are working on large scale, so they require efficient software. Now they are getting money also, they can afford softwares. But initially they used to have the free versions, few basic things, so that they used to manage the patient data, right? And provide facilities to their remote patients. So they use basic things, right? Aravind used telemedicine. So what they adopted, they gave cameras, basic cameras and internet facility to their technicians and ask them to go and visit a village. And at the end of the day or after 2 days, they used to come back with those cameras, isn't it? So this way they survived, and they have grown a lot. Second, Narayana. Narayana did expansion in 15 years. In 15 years, they have expanded from 1 hospital to 40 plus hospitals in Karnataka and other places. Now in 15 years, so they require a lot of things, right? And managing those 40 hospitals, large 40 hospitals, it is very difficult. So they integrated the EHR thing, so that with one place they can manage the thing. They can make the policy for different hospitals by sitting at one place. Similarly, Smile Train. Initially they had no funding, right? But they started micro donations. With micro donations, they started their campaign. Now, after this growth of YouTube and other social media platforms, they started campaigning on social media and they use different platforms. But earlier they asked for micro donations. Similarly, MSF used free version software, right? And then they managed. Otherwise, you can see the challenges that MSF is facing, right? They are working on very difficult situation, still integrating technology because their vision is big, right? Otherwise, they cannot use this telemedicine, EHR and all those things without using the technology, right? So this way, and now the software that they used was open source, free of cost. Now they are using some paid version also of different softwares. So my suggestion will be, if you have asked me also, start with small things, and if you'll grow, then use technology more, but start with basic technologies, basic tools. Like for record keeping, if you have no resource, you can use the record keeping with Google Sheets, that is freely available with Google Sheets. And now you can share the Google Sheets within a second to anyone, any of the network hospital. Similarly, telemedicine. Telemedicine, you do not require software. If you have WhatsApp in your mobile, you can do the telemedicine thing, right? So you can do the video consultation with the specialist, and also you can get the prescription and all the reports on WhatsApp. Again, data. So for a small scale, we can start with a small thing. For one shop, one inventory, for one hospital, one ward, we can start with small thing. And then with the growth, we can also expand our software, our tools and technologies. Fundraising, we can start with donate, sponsor a patient, or start with micro donations. Then we will get. Now if you'll think that what micro donation, how much micro donation will help, micro donation is to, means it will take lot of time to get, means collect good amount through micro donation, then it will not be means helpful for you. If Smile Train can get and did lot of things with these micro donations, then you can also get, right? And you can also do. So do the things in a right manner. Start with small. If you'll grow, then expand your technology and your tools. So with quotation, I am stopping it here, the session 1, that is, you do not need to have deep pockets. You need to have deep purpose. So this is said by the founder of Narayana Health. So they said that, he said that you require a good vision, right? you should have a good purpose. Funding and money doesn't matter, right? So do not think about the cost, think about the purpose and think about your strategy. So this is all from my side for the session 1. If you have any query, quick query, you may ask. Otherwise, I will move ahead with another topic. Any query to anyone? Yes, please.
Thank you, sir, for this very informative session. I have one simple question. You told us one side of this digital technology. You have not told us the other side of the technology,
Yes.
the darker side of the technology. Maybe some lights or something, glimpses of that may help us here to some extent. Maybe some of us are aware of it, but that also is equally important to us. Second is, you said also about this digital, that when you invest on digital technology or different AI platforms, the reduction in cost, that is little not clear to me, because the software that we are changing in our hospitals is costing us in crores. So if you are saying us this technology, the software is very low cost or cost effective, it's dichotomy, I feel. Thank you.
So thank you, sister, for asking the question. Now the thing is, you have two questions. First is that I have not told you the negative side of using digital thing. So since I want you to integrate these technology in your day-to-day life, yes, there are many limitations, many drawbacks. For an example, if you have the documents in paper, now it cannot be stolen. But if you have digital data, that can be hacked. 2 years back in AIIMS Delhi, there was attack on the server of AIIMS Delhi. There was attack on the servers of AIIMS Delhi, and they have stolen all the data from the AIIMS Delhi server. And government has not announced it publicly, but it happened. And for 15 days, around 15 days, it took to reset that server. So definitely there is a side effect. But if we will think about those things, those side effect, then we will reluctant to use those technologies, right? So that is why I will suggest, yes, and see, if you are talking about side effect, if you'll grow at that stage where you will be able to see the side effect, then there will be some measures that can avoid those drawbacks, right? Those side effects. So there are different measures that we can follow so that we can avoid those drawbacks, right? So, and second question was, I hope I answered your first question, means you are satisfied partially. So, okay. So if you have any follow-up question, you may ask so that I can clarify it more. No, I am not agreeing with you. I completely disagree with you. Sorry, but the thing is, if you are saying that, yeah, there will be side effect of the technology, I will not adopt it. There will be, if I will go by bicycle, I will ride a bicycle, I will fall, I will have injury, then I will never use this, right? So the thing is, you should use. Otherwise, what will happen, sister, that after 1 decade, you will feel that you are outdated from the market, and many newcomers will come and will grow in front of you. That is my perception. And second thing that you asked is about the cost. Yes. So again, the same thing. See, if you are thinking that integrating technology will add cost, that is true. That may add cost, but again, if you'll see in the long run, it will make the entire system cost efficient. It is like your computer, right? Like your calculator. So you used to do the task manually, right? You invested 200, 500 rupees for a calculator. Now, the initial cost was there, but in the long run, that makes your work so easy that you have covered the cost of that calculator with your efficiency. So that is why people are investing. People are purchasing laptops. Yes, it is costly. Initially, we require the cost, but in the long run, if you'll see, initial cost will be there, but in long run, it will make your entire expenses less, right? If you'll calculate for 2 years, 3 years, then it may reduce your expenses, right? Anything else, sister? Okay, please, please.
Not a question, but just some few things that we need to consider. I mean, definitely there is no doubt that we need to adopt and we need to move, and otherwise we will be left behind. I mean, there are so many examples like that. But when we talk about, I mean, I'm going by pillar. First pillar was the telemedicine. Even a small phone call, when we answer and tell them, there is also a liability for us.
Yes.
So there is a telemedicine guidelines that everyone needs to be aware of, and government has given certain 3 years leeway for us to train ourselves, because every doctor has to go through the training and get a certificate, otherwise they will not be able to use telemedicine. So there's even documentation also things you need to keep in register. Whether you keep it digital form or in analog form, even a phone call, even if you prescribe someone in WhatsApp call saying that this is what you need to take, that has to be documented. So it's not as easy as saying that, adopt, but with adoption, whatever other caveats are there, we need to be aware of. And also a basic awareness of what all constitutes telemedicine. Because telemedicine is not just having a video call and consulting patient with that. Phone call, answering SMS also is telemedicine. And in terms of EHR, I mean, I know of several network of hospitals who are functioning in remote and rural areas, who are part of a same group, have been trying, and they've been facing a lot of challenges. One is interoperability. Then another one is each hospital has their different system. Even if they're owned by the same governing body, but the way they function is different. So there has been a challenge there, and now with government has this digital health stack. And under digital health stack, there are a lot of things that are coming up which we are not aware of. One is, once we go into that EHR, our EHR has to be linked with the public. So it's not your hospital data, your patient data will not be for you only, but it will be available for the government to be able to, for the patient to be able to mobile anywhere, so that the patient can go and wherever they go. So that way there are different standards. So right now, whatever EHR that we're using, they won't be functional then. Then we'll have to go for LINAC or HL7. There are different standards which are there, which we have to meet, and these are very expensive ones. And these are, like sister said, these EHRs are very expensive, and also, I mean, here you might be getting bigger number of responses from bigger hospital. But if you look at the number of bigger hospitals are far more lesser than the number of smaller hospitals and smaller clinics, where the critical mass of patients are not there yet to be able to adopt so much of technology. That a few things that we need to consider. And also, I mean, similar to that also in terms of decision for data, data for decision making. So we don't have that kind of critical mass at many places to be able to utilize that. I mean, bigger hospitals, of course, they can, and I know of how corporate hospitals use that to have a dynamic pricing for patients. I mean, we had that dynamic pricing for railway tickets, but there are corporates who are using patient data to have a dynamic pricing. If they see that this patient is getting better soon, increase the cost, per day cost. If the patient is, will stay longer, slightly decrease the cost. That's how they are playing with data to make more money out of, patients. And of course, I think as big healthcare networks, I mean, one of the thing that next to the government the public healthcare system, the Christian healthcare network, which includes the CHAI and CMI, we have around 80,000 beds. That is the next biggest healthcare provider. And if we have
80,000
80,000 beds,
beds.
80,000 beds, more than 80,000 beds, that's the one of the, in terms of private, we are the biggest healthcare provider, more than your Apollo and Fortis and anyone else. But we are not there in the policy making as yet. And I think it is also good for us to see, as a healthcare network, how can we have our own dashboard to see that what is going on where, to have a centralized way of seeing that what kind of morbidity, what kind of mortality is going on, so that we can contribute to the national, data as well.
Anything else?
I mean, also, yeah, for the fourth one,
It will be
digital fundraising, we also have to be aware about, the risk that we are exposing ourselves to when we are posting a lot of social media things. We have to be smart enough to, be there but not be seen. Sometimes being seen also can create a problem. And without seeing, you cannot do fundraising. So we'll have to look at innovative ways of engaging in fundraising as well. So yeah, just some of the few things that insights that I wanted to share as well.
Yes. So I want to have a comment on his. I want to make comment. Yeah. So the thing is that you said that you are bigger than your network is bigger than Apollo, but yes, good. That I agree. But still, the Apollo network they are having is working more fluently and more smoothly, and you are not working. So something is required, right? So I'm not saying against it, but whatever I come to know that you are a very big organization, but you have no collaboration, that I will discuss. So lot of things. You said that we require a unified dashboard. Yes, you require that. Otherwise, how you will say that we are bigger than Apollo? You are scattered. You are in remote area. You are working there, and there is no collaboration between the health center that is there in the remote area and the health center that is there in the city, or big hospitals there in the metro. So there is a gap, right? We need to admit. Okay.
You also have to understand, when it is Apollo, the governance is Apollo. But here, if it is
Yes.
100 hospitals, there will be 30 different.
No, I'm not saying that please follow Apollo. I'm not saying that. But the thing is that you should admit that there is a gap, right? Collaboration is not going to not happening, right? There is no good collaboration between the big hospital and the rural health centers. So there should be some collaboration required, not fully. I'm not saying that every means the big hospital will own that health center, small health center. I'm not saying that, but we should able to, if you want to expand yourself, there should be some collaboration. If someone is strong, they should pull the weaker people, right? So that is what I want to say. And the second thing, you said many things. Quickly, please tell which issue you raised.
Just give comment in terms of even
Compliances. See, what happens that you please understand that as per my knowledge, you have very less fund, and there is decline in the funding or traditional funding. And second thing is that you have to work at that place where no one reaches, right? Means remote area. You are working in jungle of Jharkhand. So if you'll think too much about the compliances, regulatory compliances, telemedicine, government is saying this, government is saying that. No, if some tribal people are or is coming to you and asking that I am having a very high fever, you need to give the medicine with the suggestion from the specialist. So these things, somewhere you have to manage. And regarding EHR, you said, yes, there is a policy which is not very much strong, but in foreign we have GDPR and many strong regulations. So and in California, like we have a California Consumer Privacy Act, CCPA. So there they used to say that if you are collecting data from a user or from a patient, then that data without the consent you cannot transfer to anyone. So there is very strong guidelines. But here, who is following, means I'm not against the guidelines, but the thing is, the owner of the data will be patient. And without the consent of patient, one doctor cannot transfer the data to another doctor. So this is the actual guidelines, right? And it is not like that, that if you have collected the data, you will share to public. No, that is again a crime. So you cannot share anyone's personal data to any other person, especially the medical data. Medical data is considered very sensitive. So you cannot share the data. But the thing is that start with small, right? Do not worry too much about the regulatory thing. If you are doing on large scale, right, then you need to worry, right? So that is what I am saying. I have seen that you have different sections, different sectors, right? For, as sister was saying, that people from Kerala region, from North region, there are many regions, right? So you can implement those things in those regions where there is very, means there is a scarcity of good healthcare, right? There, and if we, again, if I will compare with Apollo, so what guidelines Apollo is following? What guidelines Apollo is following? If you said that EHR, there is a strong guidelines from the government and this and that, you go to Apollo Hospital, they will collect your data, they will save your data in the server. Now, again, you go next day to Apollo, this pharma 24/7, and one pharmacist will tell you that, okay, yesterday you got the consultation, I have your prescription, I will give you the medicine according to that. Everything is open, right? So I'm not saying that if they are doing wrong, you do wrong. But first thing, admit that we do not have that much of a strong guidelines or a strong regulatory compliances that other countries are having. First thing we need to accept. And second thing we need to accept that we are working in a place where no one is working. So for expansion, for the betterment of the people, we can implement at the local level, at a small level. When we will grow too much, right? When government will ask us to follow the guidelines, follow the compliance, that is my perception. You need to do that. But what if a small village or rural areas or tribal areas, people are having no government facilities, no hospital, nothing. There, if you will follow too much rules and regulation, you will not get, the purpose will not be solved, right? This is my perception. Yes, quickly.
Lot of fears and anxieties have been shared. The reality is that we are living in a digital world and we can't ignore it. And there cannot be any work, there cannot be any progress for us if we are not moving in that direction. One of the unfortunate things about Chai has been that we have not been able to move timely in terms of digital developments. We are talking about a network of 3,500 people in which we are even now today struggling with basic data about the contact of those people, even the address of those people. So we are far behind, and some baby steps are being taken today. And I think we must all be very happy to move in that direction and do whatever best is possible. And even the latest attempt to even collect data under the ComCare program, which we launched a few months ago, even after a few months, how many we have been able to get? Are we able to get about 500 even now? We are not able to get. I know that in my region, we have not been able to get even 25 people's ComCare registrations. So we are already very slow, and we have taken some baby steps. I think we should all be very happy to be part of it and do the best possible. And if we don't do this, we are doomed. The government, we could complain that they are slow, they are not doing things, but at the end of the day, the entire work that happens in the government system, by the end of the day, the capital is able to come and tell you how many births have been this day, how many deaths have been this day, what all things have been done. But we as Catholic, health agency, with so much of educated people being part of it, that we are not able to, get even basic data, leave alone, the daily updation of things. We are far behind in those things, and if we don't move towards that direction, we are doomed. So I appreciate whatever baby steps are being taken. I think we should all be very happily join with that and do and move forward, than look at it with fear and with anxiety and try to pull back. Thank you.
Yeah. So yes, I completely agree with him that the level of knowledge or the level of skills that I am seeing to you people, and you are working in remote areas, you believe me that no Apollo or no other network hospital can match the level of skills that you are having or the level of experience that you are having. I do not want to compare with anyone, but the thing is that the level of experience or the level of skills you are having, compare it with the small corporate hospital. I am finding big gap because I have no option to visit any chai hospital. I used to visit corporate hospital because I have corporate card. But the thing is that you can compare. There is a lot of issue, and they are doing a lot of bad things. So yes, initial there will be challenge, but again the thing is, if you will not do, then within a decade, any newcomer will replace you. That is my perception. So it is not easy. I can understand you have a great legacy, but the thing is, see, finally what will happen, if the growth will happen, tribal people will also be able to compare that whether I should go to Chai hospital or some other hospital, right? So, all right, so ending the session 1 and session 2, we have a small topic. So discussing the session 2 and thereafter. So session 2 says that technology, if you are able to adopt, then alone technology will not work. With that, you need to have a proper strategy and good collaboration. Good collaboration, in your case, I will say that there should be a strong collaboration between your networked hospital or health centers. Region wise, it can be region wise, it can be area wise, it can be city wise. So you need to understand this. But collaboration is required because a standalone system will not work a lot, right? So there should be strategy, good collaboration, and adoption of good technology. If you will combine them, then it will work in a good manner. Otherwise, there will be alone nothing can do. If you are ready to invest too much money in the technology and you have no good strategy, then it will not work, right? So it is like a triangle. If one hand will be removed, right, so remaining two hands will not survive, right? It will fall. So that is why strategy, technology and collaboration, all three will combine together, then it will solve the purpose, right? Now this integration, if you'll think, it is not optional, again it is essential. You need to have these three things in your organization. Now for that, you should first figure it out what strategy you need to follow, from with whom we need to do collaboration, and what technology we can use. It all will depend on the situation. If you have money, you can have good technology. If you have good strategy, you will definitely have the good set of technology. And if you have money with collaboration, or you are getting money with collaboration, then that will also make you at a higher place, right? So that is why things always we need to focus. Alone technology will not help. So collaboration, you know from where to collaborate. You can have government partnership. Government partnership, you might be thinking that government partnership is not easy, government is not willing to do participation. See, government partnership doesn't mean that government will fund you. Government partnership means a small government program. Like many sisters said that Anganwadi or some, what they said? Asha worker. So Asha worker, Anganwadi, they do some collaboration or whatever. So at many places there may be no Asha worker or may be no Anganwadi. There you have the reach at those places. So definitely you can propagate the government programs, right, with having some collaboration or showing some showing your effort for that program. You can have some kind of collaboration at program level. Not the entire government agency will support you, but at program level you can have the collaboration, right? For an example, we can have for vaccination. So polio nowadays, they are not, means polio is over, right, from the country. Still we give vaccine. So still vaccine is used to give. So in tribal areas you can have the vaccination thing, right? So CSR and corporates. So you can have some collaboration with small organizations, right, for a specific purpose, for one specific purpose. So earlier I had heard that Bill and Melinda Gates Foundation used to give some money for polio eradication in India. They used to give money in early 2000, right? So this way you can have some little bit collaboration with the organizations, right? And then you can expand it and see somewhere you need to start. So every dimension, it is not like that, no, I will go for micro donation only. Every dimension you should grow, right, move. Third thing is NGOs. NGOs can help you. So many sisters told that we will collaborate with NGOs for this. We will collaborate with Panchayat and Panchayat level collaboration will be there. So this way you can have collaboration. You can have collaboration with academic institutes. So you have, I had seen in the website of CHAI, there are many collaborations with different institutes across world. So such kind of collaboration, so that R&D and some small researches also can be done together to improve the healthcare of the country. Again, local communities that you told, that panchayats or collaboration with parishes, that you do, right? So at that level you do the collaboration so that you have the idea that what is what is the problem of this area and how to approach the people. So technology we had discussed, you can have, and see, it is not about these 4 technologies. You can have few more also, but start with somewhere so that you can use it and grow yourself. For an example, maternal care. Few people have discussed that we can reduce the maternal deaths. So a strategy is to reduce the maternal deaths, and collaboration for that we require collaboration with NGOs or panchayat level or with some government wings, so that that can be executed. And technology that will be used is tele-obstetrics, since means again the telemedicine or some other technology also you can use. So this way, strategy, collaboration and technology, that will be very much effective. Otherwise, standalone technology implementation, no good strategy or no good collaboration, so it will not be helpful. Again, for uninterrupted drug supply in different areas, suppose some epidemic happened in some place. Now, you again require a good strategy, good collaboration and good technology to execute the entire things. So again, these three things are required. For an example, you are expanding preventive care in villages. Now this is your strategy, you require collaboration. Collaboration, someone said that people used to go to chai tapri or people used to go to schools, so we can have collaboration with them and then we will execute our plan. So collaboration at different levels you can do. Technology, again, any existing technology, basic level technology or advanced level technology, it is up to you. If your pocket is allowing, then you can use it, right? Now, in the morning, Father VC told about LV Prasad. So I am going to briefly discuss about the LV Prasad. So LV Prasad Eye Institute, so they started in 1987. Here they are having 4 branches in Bhubaneswar city, LV Prasad. So they started in 1987 and the mission was universal access to quality eye care. So Aravind was older and LV Prasad is newer, right? There is few difference between Aravind and this LV Prasad, because LV Prasad used the pyramid model. Pyramid model means LV Prasad said that we will work at 3 levels. We will work in metro, we will work in class B town, and we will work in poor areas, remote areas. So they followed the pyramid. They are working at 3 different places. Now, they will gain money, that is again cross subsidization, right? They will gain money from somewhere, they will spend money at somewhere, right? So they have vision centers at village, they have secondary centers at town, and they have tertiary hospitals at metro. So it ensures that every Indian has access to affordable eye care close to home. So they did lot of collaboration. LV Prasad, if you'll go on the website, they did lot of collaboration. They have collaboration with NGOs, many NGOs, right? Now LV Prasad name is so big that now many NGOs want to do the collaboration. It is not the LV Prasad going for the collaboration. NGOs are coming for the collaboration. Similarly, CSR, so they are working with Infosys, they are working with Microsoft India, they are working with Nadella Foundation. So Infosys, they are using for funding the eye care centers. So Infosys using CSR to fund the centers. Microsoft, they are using for AI tools to check the retinal disease detection, means they capture the photo and they use AI tool of that image and they try to find that there will be some problem or not, right? So AI is using image to tell the problem. Again, they are using Nadella Foundation for Community Vision Initiative, and similarly they are using lot of collaborations. They are also collaborating with local health worker, trained volunteers. So they have different level, like Father said, that they are good for rich people also and they are good for poor people also. So everyone will go. Believe me, if you'll ask the people from Bhubaneswar that if you are having a serious eye problem, they will directly go to LV Prasad. They will not go anywhere else. So technology, they are using ophthalmology, means again telemedicine. Digital equipments they are using, AI tools they are using, right? And they are having currently 200 plus vision centers. They have screened million of people, and they have self-sustaining model. means patient who can pay, subsidize those who cannot, and recognized globally as a replicable model of integration. So there should be a clear strategy in CHAI also, and there should be a good partnership and community engagement that make the mission sustainable, and use technology as an enabler, not the driver. Technology will help you, not will guide you, right? So you require to use technology to get the assistance, get the help, right? To make yourself efficient, to enhance the performance, right? So benefit of integration is there will be better patient outcome, there will be enhanced trust, and there will be good visibility, there will be financial sustainability, and there will be less staff burden, right, through shared partnership. And see, again, if someone has a resistance, that can be, that is natural, right? So resistance to change, why we should adopt technology, there is lot of problem, we may face lot of problem. So that is why I am saying start with small things you adopt, right? If you have confusion, if you are not sure about it, start with small, right? It is not like that government is coming and catching you, right, for good purpose. Use low cost or free tools for the technology, right? Give proper training to your staffs, regular training to your staffs, and use simple solutions, right? So these things will help you to have the better coordination among your organization, among different health centers, and to solve your purpose in a better way. So this is all from my side, and now my task is over, your task is going to start. So in the first session, in the start, I told you that write about the challenges that you faced in the past, what strategy you followed, what collaboration you did for that, and what technology you used. Now, you have studied all the things, you come to know all the things. Now, the same challenge, now what strategy you will follow, what collaboration you will do, and what technology you can use. So here you can use your imaginative skills little bit. Earlier it was realistic, right? Realistic means what you had done in the past. Now, what add-ons you want to do so that there will be change in the strategy, change in the technology, or you do not want to change anything, right? So again, you do the same thing in the back side of your chart paper, and the session will be over within 10 minutes. Time starts now. Write it in the back side. I will not take much time. I understood one thing, that the session was very boring because it was kept after lunch time, one thing. Second thing, it was little bit overload, right? It became little bit heavy, too much theory and too much of lectures. But still, I am giving you task, complete it.
It is highly content oriented, robust content.
Yes.
This content they will never find.
Is it over? Yes. Please provide the chart paper. If it is completed, please provide.
Then there is no need to present, ma'am.
I will just read it out.
Very good.
Yeah. So please provide your chart papers, right? So I am going to read the answers of group 6. So earlier group 6 was having shortage of doctors. That was the challenge they picked. Now they used the strategy, they used telemedicine and collaboration. They used CHAI and other big mission hospitals. And technology, they used telemedicine. Collaboration with strategy, that they mitigated it again with the telemedicine. Now, their newer answer is challenge they face shortage of doctor. The strategy they followed is digital intervention. Collaboration, they will follow CHAI and other missionaries same. And technology again, telemedicine with EHR. So they have added EHR in the technology section.
Okay, this is the group 2. For this time, our group, we are not vaccine warriors anymore. We are 2 to tango with technology. So shortage of doctors is the problem, because of which no doctors, no patient coming. And because of that, it is also increase in maternal mortality, and no patient coming. We are not raising any money. So these are all the problems that we are facing because of a major problem is shortage of doctor. So what's happening is we have doctors from St. John's and who are coming and doing their bond in this hospital. And there's also tie-up for rural bonds, and also for internships people could come and do. So that's how the need was met. And there were also calls and emails, and also telemedicine was used to meet the shortage of doctors, which was from CHAI. So now with learning with all the 4 pillars, what we did was for recruitment, we thought we could also make compelling videos and put it on the social media, and also a good video documentary. We can work with recruitment agency and do advertise there. And in terms of also see that there is an increase in maternal mortality and the health for the local health care. What we have also doing is, we have a lot of people we see now, even if they don't have food, but they'll have the internet and be watching reels and shorts. So we'll be using reels and shorts to promote health, and also to promote the hospital facility, what all are there in the hospital locally that can be done. And for fundraising, we are looking at crowdsourcing and platforms, and also social media to raise funds. And we'll be using EHR for patient data and patient follow-up. So these are the new technology that will be integrated along with what was done earlier.
Thank you very much. So they have added few more technology to solve their issue. This is group 5. Right? So
Should I read? This is from group 3. We had challenges with the reporting error in the hospital, mainly in the lab setup. because once upon a time it was reporting by handwritten reports. Machine were generating the reports, and it was reported by hands by human staff. But we have observed many of the reporting errors, that means human errors were occurring. Consequently, it was ending up with the court cases because, for example, we are making one kidney function test, and the reports are very high because sometimes 11.1 will be 111. Like that, we are ending up with the court cases and all. Then we start with, and we have planned a strategy that was going for a new software for lab only, for lab and investigation area. So we have developed with our IT team and our software company, that is LIS, Lab Information Software System. Now it is working with, and we had a long training session for our staff. We had trained them. Also we had some change management because it's a changing, it is using with so many registers. So giving up the these registers and going straightly from the machine to software and software to computer, then computer to the printer, and directly we were taking the print, and it was little challenging for our staff, those who are using so many years with handwritten reports. Now this is functioning very well, and these reporting errors are very less, even sometimes zero level reporting errors. Now it is functioning very well, and we monthly or very frequently we do annual evaluation. Now it is functioning very well. This method used is technology, that is new software for it. So it is successfully working now.
Now there is no human intervention.
Everything was machine. Yeah.
So report is coming from the machine, and it is going to the getting into the computer.
Interface.
And the printer is printing the output. Thank you. Yes. So no, it is there. So sister was saying that now everything is computerized, so there is no error. Earlier there was error. So they are using a software, paid version software, and it is helping a lot, right? There is group 5. Group 5 had the challenge of shortage of doctor in rural areas. They think that they need to collaborate with the local doctors. That was their strategy to mitigate the shortage of doctor. They collaborated with local doctors, and this was done by them. Now their new answer is that the challenge was shortage of doctor. Strategy is now they will follow is telemedicine EHR, digital fundraising, cross subsidization method and model for shortage of doctor. Collaboration, they will link with other CHAI hospital or government agency or other NGOs. Technology, micro level fundraising, CSR, storytelling, visibility of our service, commerce, digital patient feedback, start small, grow big. Where is group 5? Okay. So group 5 has written all the things that I told in the PPT. No. All right. Other group, please. Please. Yes, sister. Yes, sister, if you want, please. Want to present?
Our challenge is shortage of doctors in rural areas. Our strategy is that to mitigate shortage of doctors, collaborate with higher centers, CHAI, health camps, networking with healthcare workers in the villages. Then technology that we are going to use, telemedicine and mass media. Thank you.
Thank you. Okay. Group 8, again they was having, the challenge was shortage of doctor. So more or less, I come to know that there is shortage of doctors. So the strategy was career incentive, PG super specialty preferences, policy measure, compulsory service after UG or PG to the remote areas, perhaps they want to say, professional caring environment, environment friendly, and rural subsidization program. Is it that subsidization? Sensitization? Okay, rural sensitization program. Collaboration, they collaborated with St. John's Medical College, Catholic Academic Medical Institutions, NGOs, and other colleges. And technology, they use social media, WhatsApp group, hospital website, publication of success stories. It is the latest one. Yes, yes. So earlier, the technology they followed is social media ads, Doctors for India and doctors outside the border. They collaborated with few doctor group, and their strategy was to promote word of mouth and social media to find the doctors so that they can serve to their centers. So that was their prior strategy. Now they have modified little bit.
Ours is 9th group with all the CHAI board members. The biggest problem, challenge, that is financial sustainability. So first, before the class, we have they wrote challenge is financial sustainability, and strategy is increasing the patient's admission, appointing CFO, make use of CSR fund, and collaboration tie-up with insuring companies and industries. Then technology, software, and media. So after the class, the problem remained same. That is financial sustainability, and the strategy is to improve the quality of service in our hospitals, our institutions and all. Then collaboration with the government and tie up with the big companies and all. Then technology is digital media, telemedicine, and EHR. That's all.
Yeah, thank you. So the strategy was to strengthen the trust between patients and doctors.
From group number 1, our challenge, shortage of doctors, and our strategy followed telemedicine, already following with a positive culture and the team building. Our collaborators, we have the small hospitals registered under St. John's Medical College, so that the doctors, they come to our rural centers, and technology followed is web-based applications. After the class, challenge remains the same, and the technology followed as telemedicine, as already we said, and using the technology systematically. After the sir was giving some explanations, we understood certain problems involved in it, and fundraising, micro and macro with transparency followed, collaborating with like-minded people, and accessibility to the modern technologies, cross-subsidization, that is charging the rich people and helping the poor people, collaboration with like-minded people, and marketing and networking. We are also collaborating with our alumni students, those who are in the education. We also have the education, no, colleges, schools. From there, our old students, those who are able, doctors, those who are able to collaborate with us, we are also collaborating with them.
Yeah, thank you.
From Group 10, our problem is poor record keeping and audit challenges. We are coming from small hospital setup, so this is what we are doing. Strategies, simple computerizing and manual entry. After attending the class, we got some insights. That is skill training in data management, use Excel, Google Sheets, open resource softwares, fundraising strategy, and migrate to a professional software when it is ready. Thank you.
Thank you, sister. So 2 things I want to say about the sister. 1, see the art, very beautiful art. And second thing, she said that her hospital is small. That is not small, that is 35 bedded and soon going to be 70 bedded hospital. So it's a big hospital, right? It is difficult to find 70 bedded hospital too much in Bhubaneswar city. And perhaps this is the last group. So group 4, they had initially they had a challenge, they faced challenge that use of advanced technologies, ignorance of technology, not interested, means they were this was previous answer. Other side was previous answer. So challenge was they were losing patients. So there was decline in patient, means the continuity is not there, right? So the patients who are going to government hospital or private hospitals, they were not coming to their health centers. The strategy they used is mobile clinic to improve the outreach, and they used low cost quality care, and they used telemedicine. The collaboration that they did with NGO and local village leaders. Technique they used was social media and follow-up strategy, means they were perhaps calling to the patient, what happened to your health. Now the new challenge, they have new challenge now. After the class, they have new challenge. The challenge is reluctant to use technology. They are not interested. So what strategy they are going to follow is interest to know and get trained people, and they want to use telemedicine. Collaboration they will do with NGO and experts with different organizations. Techniques they want, technology or techniques they want to use is they want to appoint experts in their institute, their organization, IT expert, data managers, and then they want to integrate EHR. Means they want to use EHR but with some experts' help, right, with the guidance. So this was the answer of, this is the answer of group 4. I think all groups are over, right? So this is end of my session. If you have any doubt, anything else you want to say, you can say after the end of this session. And I am very happy that I got the opportunity to interact with you, right? Thank you very much.
We sincerely thank you, Dr. Ashish Kumar, for your thought-provoking session. Your insights were both practical and inspiring, offering us new perspectives to strengthen our mission. We truly appreciate the clarity and depth with which you guided us, making the session highly valuable, at the same time disrupting us with some disturbing thoughts. Let us hold to heart the quote of Devi Shetty that you need not have a deep pocket, but need to have a deep purpose. And let us take small baby steps to integrate strategy, collaboration, and technology to enhance our mission. Let us all start small and grow big. May I now ask Sister Tina Papachan, National Board Member of CHAI, to honor Dr. Ashish. Some announcements. Members of RUPCHA, followed by CHAP, Andhra and Telangana, are requested to come in front of this stage for a photo. Please fill the survey form which is sent for your travel assistance. There will be a group photo session tomorrow immediately after the Mass. For the award ceremony and cultural program, we will come back to this hall at 6:30 p.m. Thank you. If any of you are interested in seeing the auditorium of Zyme University, you may go and see. It's open now. Thank you.
student of Exam University. So let's welcome her with a big round of applause. Well, that was truly divine, a performance that echoed the timeless rhythm of Odisha. Thank you, Adrita.
And now we move on to one of the most awaited moments of the evening, the Mary Glory Lillian Breckelman's Disability Award. To introduce the award, I warmly welcome Sister Dr. Jomol Peter, Vice President of Sister Doctors Forum of India.
Mary Glory Lillian Breckelman's Disability Award 2025. CHAI celebrated its Platinum Jubilee in 2018 of reaching the unreached and providing health for all. It marked 25 years of service for children living with disability in collaboration with Lillian Foundation. In 2018, Lillian Fonts announced support for the Mary Glory Lillian Breckelmann's Disability Award. The award is to recognize the contribution of two great women. Sister Dr. Mary Glory, the founder of CHAI, Lillian Breckelmann's, the founder of Lillian Foundation. The award was also a token of appreciation for CHAI's services to people living with disabilities. CHAI has supported over 33,000 children or youth with disabilities in the last 25 years. In the year 2024 to 25 alone, 7,000 plus children and youth with disabilities were supported. 4,373 plus children and youth with disabilities were given healthcare support. 2,397 plus children and youth with disabilities were provided education and support. 978 plus children and youth with disabilities were given livelihood opportunities. 5,213 plus children and youth with disabilities were supported for social inclusion. The award aims to recognize the exemplary contribution in the field of disability and to honor resilience, determination, and impact of persons with disabilities. This year, 4 awards will be presented under the category Role Model Individual. 2 awards from within the CHAI network, 2 awardees from outside CHAI network.
Thank you, Sister Dr. Jomul Peter.
To announce the winner and present the award, I now invite Father Binu Kunnat, Vice President of National Board of CHAI. The award is for individual outside of CHAI network.
So very good afternoon, very good evening, good afternoon, good morning. So even good night also, sweet dreams. So the individual outside the CHAI network, the award goes to Miss Ujini Janaki.
So, Ms. Voshni Janki was born deaf and raised in a marginalized background, has turned barriers of education, stigma, and exclusion into a lifelong mission of empowerment. She has founded the People with Hearing Impaired Network, FIN, in 2007, a disabled people's organization that champions self-driven empowerment for persons with disabilities. In 2013, she established Telangana's first residential school for deaf girls, which now educates and supports over 157 children from diverse and disadvantaged communities. She has received multiple prestigious recognitions, including the National Award for Empowerment of Persons with Disabilities, the Helen Keller Award, Best Special School Award, and the Nari Shakti Vandan Adhiniyam Award. With a vision for the future, she aspires to expand FIN into higher education, teacher training in Indian Sign Language, digital learning tools, and stronger advocacy for a just, inclusive society where disability is embraced as human diversity. So, as Ms. Voshni Janki could not be here, may I request her son, Mr. Mahesh, to kindly receive the award on her behalf. Thank you, Father Binu, for presenting the award.
For the next award, may I invite Father Devdos Thomas, National Board Member of CHAI.
Good evening. The award goes to Dr. Aswinder Kapil.
Dr. Yashwinder Kapil is a leading disability rights advocate with over 19 years of dedicated service. He currently heads the community-based rehabilitation program in Chandigarh, and through his initiatives across multiple states, he has empowered thousands of persons with disabilities by providing rehabilitation, skill development, and employment linkages. Recognized both nationally and internationally, he has pioneered inclusive development models aligned with the RPWD Act and NEP 2020. As a mentor, policy influencer, and award-winning leader, Dr. Kapil continues to champion equity, dignity, and meaningful opportunities for persons with disabilities.
Heartfelt congratulations to Dr. Yashwinder Kapil. Sir, your work is an inspiration. May I request you to share your experience with all of us?
Good evening, everyone. I started my career in the year 1998. That time I did my bachelor in mental retardation from National Institute for Mentally Handicapped, which is currently known as National Institute for the Empowerment of Persons with Intellectual Disabilities. From there I started my career, and the inspiration regarding starting my career was my father. He was a national awardee. He won the national award for the welfare of child development. He inspired me, you should go ahead and we should work for the persons with disabilities. After that, I pursued my master's in disability rehabilitation administration, and after that, PhD in special education. My job started from the Rehabilitation Council of India. I worked there as a program officer in Delhi. After that, I joined a Government Rehabilitation Institute for Intellectual Disabilities. For the last 15 years, I am working there, wherein I am helping the persons with disabilities from the grassroots level. I have placed many persons with disabilities in the various setups under the CSR, under the Taj Hotel, and many hotels like Hometel Hotel, Lemon Tree. So like that, I am helping them in the livelihood programs. So this is in nutshell about my journey to helping the persons with disabilities. So thank you so much.
Thank you, Doctor, for sharing your inspiring words with us. Music is the universal language of mankind. Let us all immerse in the harmony of an instrumental performance by our second-year students, Vedant and Kushal, who would be playing the guitar and keyboard respectively. That was truly mesmerizing. Thank you, Vedant and Kushal, for the soulful performance.
Moving ahead, I invite Sister Dr. Preeti Margaret, Joint Secretary to the National Board of Chai, to present the award for an individual within the Chai network.
Good evening, fathers, sisters, and Bishop. Bishop is individual within the Chai network. The award goes to Sister Dr. Carmelita.
Sister Carmel Arul, born in Tamil Nadu, has devoted her life to the service of the sick and disabled. A BEMS graduate with a specialization in alternative therapies, she established the Holy Cross Alternative Health Center in Odisha, providing physiotherapy and holistic care to children in communities in need. Driven not by income but by compassion, Sister Arul's mission focuses on touching lives, restoring dignity, and making the love of God known through healing and selfless service. Congratulations to Dr. Sister Carmelita for the award. May I request Sister to share her experience briefly with us.
Praise the Lord and good evening, dear fathers and sisters. A joyful heart, always filled with thankfulness and gratitude. Today I am very happy and grateful to Jesus, who trains my hands to touch the sick people, especially disabled person, with patience and care. Also, I'm thankful to the Chai family for your appreciation and encouragement through this award to go ahead to show the compassionate love of Jesus, as our congregation has the vision to make the good God known and loved. Through this ministry, we are making known the compassionate, revealing His merciful love to the people. Also, greatly I remember my sisters who helped me and supported me to take up this ministry and to go ahead to show compassionate love to the people. Also today, I like to call my dear sister who is present here, Sister Cicely John, the OCHA president and present province councillor, one of the councillor also. I like to get from her hand also. Please, dear sister.
Thank you so much, Sister, for presenting the award.
The next award is for individual within the Chai network, and it will be announced and presented by Father P.A. Thomas, National Board Member of Chai.
Good evening to His Grace, fathers and sisters. Individual within the Chai network, the award goes to Sister Elizabeth John. Sister Elizabeth John.
Sister Elizabeth Joseph, a member of the Franciscan Sisters of the Immaculate Heart Mary, has devoted over 50 years of selfless service in nursing, hospital administration, and community health. As tutor and nursing principal for 18 years and hospital administrator for 15 years, she has shaped healthcare delivery with expertise and compassion. She has worked extensively in mother and child health, disability and palliative care, and old age care, uplifting the most vulnerable. A compassionate healer and visionary leader, she has touched countless lives with dignity, care, and empowerment. Her legacy as an educator, medical counselor, and servant leader continues to inspire generations in healthcare and social service. Since she could not be here, may I request Sister Shiny Vincent, President Chai, to kindly receive the award on her behalf. Thank you, Sister Shiny and Father Thomas.
Dance is the hidden language of the soul. Our next performance is a Kathak dance, which is a classical dance of North India. Known for its intricate footwork, swift spins, and expressive storytelling that blends rhythm with grace. Performing the soulful art form is Amisha, a first-year master student of Exime University. Let's welcome her warmly.
Come on now, follow my lead. Come on now, follow my lead. Gama bala, gama ma, gama bala, gama esa, gama bala, gama ma, gama bala, gama esa, gama bani pa gama ma, gama bala, gama esa, za 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 za, gama basa, gama ma. I'm in love with your body.
breathtaking performance. The rhythm and grace were simply captivating. Thank you, Amisha.
We now move to the Mother Giovanna Alberoni Memorial Award. To introduce this award, I invite Sister Charlotte Thomas from Holy Family Hospital, Mumbai.
Mother Giovanna Alberoni was a woman whose inspiring life and mission continue to touch countless hearts. A humble missionary in the service of humanity, her visionary leadership transformed Holy Family Hospital into a renowned institution rooted in service, guided by excellence, and deeply committed to the healing ministry. Her enduring legacy of compassion, respect for life, and dedication to the sick and suffering remains a guiding light for us. She was born on October 1st, 1926, in San Giorgio Piacentino, Italy. From a young age, she felt a strong calling to dedicate her life to religious service. Responding to this call, she joined the congregation of the Ursulines of Mary Immaculate on 16 January 1946 and professed on 18 September 1948. With a heart filled with zeal and compassion, she began her mission with a special focus on healing and service. On 4th November 1948, she arrived in India, where she would devote her life to education, healthcare, and the care of the poor and suffering. She completed her medical education at Lady Haddon Medical College, Delhi, and began her career as a doctor at Mariampur Hospital, Kanpur. She went on to serve as medical superintendent and gynecologist at Nirmala Hospital, Merikunnu, and Good Shepherd Hospital, Vaithiri in Kerala, and also offered her selfless service at refugee camps during the 1970 crisis in West Bengal, where millions of refugees from Pakistan were huddled in makeshift camps. In 1978, she took over Holy Family Hospital from Medical Mission Sisters. Mother Giovanna was the pioneer and primary architect behind its phenomenal growth. She expanded its services with a strong emphasis on maternity care and community outreach, and went on to establish the Navajit Community Health Center dedicated to serving slum dwellers and tribal populations. In 1992, she was appointed as the Executive Director of the Holy Family Hospital. With her vibrant leadership and farsightedness, she directed the hospital to emerge as a premier Catholic institution in the city of Mumbai, the state-of-the-art medical facilities. Mother Giovanna served the UMI congregation with dedication through various important roles. As Superior General, she offered visionary leadership, strengthened unity among the sisters, and inspired them to live their mission of service with zeal. Appointed as Mission Secretary, she worked tirelessly for the education and empowerment of the poor and marginalized, opening the doors of opportunity for many underprivileged children. She also contributed significantly to the growth of Holy Family Hospital, ensuring that it remained a center of compassionate and competent healthcare. Mother Giovanna was the recipient of numerous prestigious national and international awards in recognition of her unwavering dedication to the poor, the sick, and the abandoned, especially women and children. In 1958, while still a medical student, she received the award for the most sympathetic medical student towards poor patients from the then Prime Minister of India, Pandit Jawaharlal Nehru. Her philanthropic spirit was further acknowledged in 1993 with the Angel of Cathedral Award, conferred by Philanthropic Foundation of a bank in Piacenza, Italy. The following year, 1994, she was knighted by Italian government for her distinguished service. In 1999, the mayor of Piacentino, Italy, honored her with the illustrious citizenship award for her exemplary missionary work in India. In 2001, her commitment to safeguarding the sanctity of life was recognized by the Solidarity for Life Award for her pro-life ministry, counseling parents who were tempted to opt for abortion. Crowned with yet another distinction, in 2012, she was awarded so-called Nobel Prize for Missionaries by Cure Amico, a Catholic founding association of Brescia, Italy, affirming her lifelong mission of compassion, service, and love. Mother Giovanna was called to her eternal abode on 18 January 2021 at the blessed age of 94. Throughout her life, she was a guiding light and a true mentor to Holy Family Hospital. It was through her vision, values, and unwavering encouragement that the hospital grew into a premier institution it is today. The great edifice of Holy Family Hospital stands as a living monument to her dedication, zeal, and selfless service. Remaining actively involved in its mission until the very end of her life, she leaves behind a legacy of compassion, faith, and service that will continue to inspire generations to come.
Thank you, Sister, for that introduction. Now, to announce the awardee, I invite Sister Sheija Matthew from Holy Family Hospital, Mumbai.
Good evening to all. Mother Giovanna Alberoni Memorial Award goes to Sister Dr. Annie Catherine Scaria.
Sister Dr. Annie Catherine Scaria, also known as Sister Rina, belongs to the Poor Handmaids of Jesus Christ, PHJC, has faithfully lived her dual calling as a physician and religious sister. A consultant physician and director of Catholic Hospital, Dhani, since 2012, she has pioneered community health programs empowering tribal communities. She established a TB diagnostic center with the government, a palliative care unit with home-based services, a nursing care assistant course, and a 4-bedded ICU to strengthen the critical care. During the COVID-19 crisis, she led life-saving initiatives supporting patients and migrant laborers, earning recognition as a JEET champion by the Government of India. Honored with the Devi Ma Ahilya Nari Gaurav Alankar Award in 2022, she continues to drive preventive health, education, and transformative healthcare for the underserved communities. Congratulations to Sister Dr. Annie Catherine Scaria for this honor, and we would request you to share a few words about your experience with us.
Respected fathers, sisters, and my dear friends, I am deeply honored to have been chosen as the recipient of Mother Giovanna Memorial Award this year. My heartfelt gratitude goes to CHAI and to Holy Family Hospital, Mumbai for recognizing my humble service with this great honor. This award is not mine alone. It belongs to all who have journeyed with me, my colleagues, staff, mentors, and the many people who have been privileged to serve. I especially remember with gratitude all the sisters of my congregation for their constant support, love, and encouragement, which have strengthened me throughout my journey. Above all, I thank God for His guiding hand and dedicate this award to the journey of my service, carried out with humility, simplicity, and love. Thank you, one and all.
Thank you, Sister Charlotte Thomas and Sister Sheija Matthew.
As the evening nears its close, what better way to celebrate than through the joy of music? Presenting a group vocal performance by our talented first year MBA students, Ashika, Yash, Anuraj, and Shriya.
Hello, hello.
Hello.
आशाएं 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 कुछ पाने की हो आस आस कोई अरमा हो जो खास खास आशाएं आशाएं हर कोशिश में हो वार वार कर दरियाओं को आर पार आशाएं आशाएं तूफानों को चिर के मंजिलों को छीन ले आशाएं खिले दिल की उम्मीदें हंसे दिल की अब मुश्किल नहीं कुछ भी नहीं कुछ भी आशाएं खिले दिल की उम्मीदें हंसे दिल की अब मुश्किल नहीं कुछ भी नहीं कुछ भी ओहो उड़ जाए लेके खुशी अपने संग तुझको वहाँ जन्नत से मुलाकात हो पूरी हो तेरी हर दुआ आशाएं खिले दिल की उम्मीदें हंसे दिल की अब मुश्किल नहीं कुछ भी नहीं कुछ भी बेरंग सी है बड़ी जिंदगी कुछ रंग तो भरूं मैं अपनी तन्हाई के वास्ते अब कुछ तो करूं जब मिले थोड़ी फुर्सत जब मिले थोड़ी फुर्सत खुद से कर ले मोहब्बत है तुझे भी इजाजत कर ले तू भी मोहब्बत इन दिनों दिल मेरा मुझसे है कह रहा तू ख्वाब सजा तू जी ले जरा है तुझे भी इजाजत कर ले तू भी मोहब्बत है तुझे भी इजाजत कर ले तू भी मोहब्बत There shall be showers of blessings. This is the promise of love. There shall be seasons refreshing, sent from the Savior above. Showers of blessings, showers of blessings we need. Mercy drops round us are falling, but for the showers we plead. There shall be showers of blessings, precious reviving again. Over the hills and the valleys, sound of abundance of rain. Showers of blessings, showers of blessings we need. Mercy drops round us are falling, but for the showers we plead. But for the showers we plead. But for the showers we plead. Thank you.
That was truly soulful. 4 voices blending into one. Thank you all for that melodious gift.
I now invite Sister Helen to honor our young performers. I now invite Sister Helen to honor our young performers with a token of love and appreciation for filling this evening with culture and grace.
May I call upon all those who have participated for today's cultural program. It was soul touching as they were very much inspiring and it was so melodious. Come forward, please. Thank you very much and congratulations. May I call upon Father Matthew Abraham, the Director General of CHAI, to give a words of appreciation to all our participants here.
This was not planned, okay? This is a last-minute intervention. I would say that you young people inspired us, okay? So I'm going to do something unconventional. It's not a, as a gratitude, I'm going to sing a song. I am singing it because the president of Chai told me we need to sing, okay? So this is not going to be a solo performance, it will be a group performance, okay? All of us are going to sing. I report to the president, so when the president tells me, I have to oblige. This is a song which is familiar for most of you who are born and brought up in Kerala, okay? So we will sing together. Others can hum it if you don't understand the lyrics, okay? The lyrics goes like this, Airam kannumai kathirunnu ninna njan, okay? Right, let's begin. Airam kannumai കാത്തിരുന്നു നിന്നെ ഞാൻ എന്നിൽ നിന്നും പറന്നകന്നൊരു പൈങ്കിളി മലർത്തേൻ കിളി പൈങ്കിളി മലർത്തേൻ കിളി ആയിരം ആയിരം കണ്ണുമായി കാത്തിരുന്നു നിന്നെ ഞാൻ എന്നിൽ നിന്നും പറന്നകന്നൊരു പൈങ്കിളി മലർത്തേൻ കിളി പൈങ്കിളി മലർത്തേൻ കിളി മഞ്ഞു വീണതറിഞ്ഞില്ല പൈങ്കിളി മലർത്തേൻ കിളി വെയിൽ വന്നു പോയതറിഞ്ഞില്ല പൈങ്കിളി മലർത്തേൻ കിളി മഞ്ഞു വീണതറിഞ്ഞില്ല വെയിൽ വന്നു പോയതറിഞ്ഞില്ല ഓമനേ നീ വരും നാളുമെണ്ണീരുന്നു ഞാൻ പൈങ്കിളി മലർത്തേൻ കിളി വന്നു നീ വന്നു നിന്നു നീ എൻ്റെ മന്മസാഫല്യമേ വന്നു നീ വന്നു നിന്നു നീ എൻ്റെ ജീവചൈതന്യമേ ആയിരം കണ്ണുമായി കാത്തിരുന്നു നിന്നെ ഞാൻ എന്നിൽ നിന്ന് പറന്നകന്നൊരു പൈങ്കിളി മലർത്തേൻ കിളി പൈങ്കിളി മലർത്തേൻ കിളി പൈങ്കിളി മലർത്തേൻ കിളി പൈങ്കിളി മലർത്തേൻ കിളി. Thank you. That is for you. All right? Meaning of the song. This is a very romantic song, okay? This is not a Christian hymn, okay? This is a romantic song which we used to sing during our college days, okay? But the twist is, this is the love between a grandmother and her daughter, okay? So this movie was very famous in Kerala. So the grandmother was singing for her granddaughter, who had been away from her for a long time, comes back, but she was dying of cancer, okay? Not the grandmother, but the daughter, the granddaughter. So she sings when, during an emotional moment. It's a beautiful hymn, Ayiram kannumai kathirunnu ninne njan. That means I've been waiting for you with 1,000 eyes, okay? എന്നിൽ നിന്നും പറന്നകന്നൊരു പൈങ്കിളി മലർ തേൻകിളി. The one who flew away from me, okay? The bird who flew away from me. മഞ്ഞ് വീണതറിഞ്ഞില്ല. That means I did not realize the snow falling. Maybe the season's changing, okay? വെയിൽ വന്നു പോയതറിഞ്ഞില്ല. That means I did not recognize when the sunshine came and went. ഓമനെ നീ വരും നാളും എണ്ണിയിരുന്നു. The rest maybe I can tell you in private, okay? All right. So thank you. That was dedicated to you, right? Thank you so much. Right. Okay.
Thank you, Father Matthew Abraham, for that wonderful song. So we are Team SPICMECE exam chapter, spearheaded by our faculty coordinator, Dr. Professor Kalpana Sahu ma'am. Thank you all for giving us this opportunity to be the hosts for this evening. I extend my heartfelt thanks to all our dignitaries, guests and performers who have made this evening truly memorable. May I now request Sister Helen to kindly share the announcements regarding dinner and tomorrow's program, including the timings. And with that, we bring this beautiful evening to a close. Good night, everyone, and may God's grace continue to shine upon us.
Dinner will be served in the dining hall in IC2 building. All the students of AGBM University who are here are requested to join us for the dinner. And about tomorrow's Mass will be in the same chapel at 7:30 a.m. tomorrow. Thank you.